Marco.
Sean, here we are, and we just missed someone.
Look at that. Dr.
That
Pearl.
close.
That close.
I'm sure he'll be back.
Yeah.
But for everybody who's on live with us, thank you all for joining us for an ITSPmagazine webinar where, I mean, look at this panel. Great people, great topic. We're going to have some fun today and appreciate you all joining Marco and I as we host this conversation with some of the leaders in the healthcare space, covering technology and the whole ecosystem from patient to provider and up and down the whole stack there. And so just a quick word about ITSPmagazine webinars. Basically, we're going to bring together groups of people like this to cover topics that are on your mind and perhaps maybe not on your mind. And today's topic is AI in healthcare. I think AI is a topic everywhere. I was just at a legal conference and it was probably a third of the topics were AI related. But we're going to look at it today from the perspective of who benefits, who pays, and who pays the price if the risk isn't mitigated. And we're going to use as much of the hour as we can to kind of explore that in every facet of the healthcare ecosystem. So, Marco, I'm going to introduce folks if we're ready to roll.
Yeah, of course. This is our first webinar, so I'm very excited about it, and it's a great way to start. So I don't want to hold off. Let's go and roll.
Right. So Dr. Pearl was with us. Hopefully he'll be joining us again in a minute. We also have John Sapp, Jr., who's VP and CISO, Texas Mutual Insurance. We have Jim StClair, who's VP of Public Health Systems at Altarum. Robert Havasy, who's Senior Director of Connected Health at HIMSS. And certainly last but not least, Robert Booker, Chief Strategy Officer at HITRUST. And we're all going to have some fun here. This first question was going to be directed at Dr. Pearl. I'm gonna see who wants to take this. Maybe Rob. I'll go with you, Havasy. Oh, look at that. Oh. Dr. Pearl's back.
I'm sorry, I was on the whole time. I just couldn't be heard. Sorry.
Oh, there we go.
Well, we're live, so welcome back.
Best timing I've ever seen.
Heard it all.
Look at that. And we're going to cover your face for a second with your name. So Dr. Pearl, former CEO, Permanente Medical Group, author, and all-around good guy, doing some good stuff in this space. So, Dr. Pearl, the first question goes to you. What is the state of AI in healthcare? Kind of paint the big picture for us so we can get the ball rolling here today.
I think we have to look short-term and longer-term. Today, what exists are two sets of applications. One that's very powerful is the ambient listening in the clinician's office, where a generative AI tool will listen to the interaction between the doctor and the patient and generate electronic health notes, which was one of the biggest complaints clinicians had as they were staring at their screen rather than seeing their patient and spending 1 to 2 hours a day documenting the visits for insurance claims and prior authorization requests. So that is a solution that's in place. Quite a number of companies are doing it. And there are a variety of other administrative tools, particularly ones that allow doctors to obtain prior authorization and complete the claims billing process, payment methodology that's required. But I think the biggest opportunities are way beyond that. And as you say in my book, ChatGPT MD, How AI-Empowered Patients and Doctors Can Take Back Control of American Medicine, I focus on the patient first and the ways that this technology will allow us, I think, to save hundreds of thousands of lives, be able to make healthcare affordable for Americans, and actually reduce the burnout clinicians feel because it starts with empowering the patients. And I'll just briefly mention one area that I think we can dive back in the rest of this podcast today, this broadcast today, and that is specific to chronic disease. Chronic disease accounts for 70% of doctor office visits, 70% of medical costs. Their complications are heart attacks, strokes, kidney failures, and cancer. We do a relatively poor job of managing them today. We have 400,000 people who die annually from misdiagnoses. We have probably another 500,000 who die from the fact that we control hypertension, diabetes, heart failure, nowhere near as well as we should be able to do so. And this technology is sitting on the edge of being able to provide that, particularly after the most recent release of a tool called DeepSeek by a Chinese company that's open source and will allow entrepreneurs to build on top of it.
Rob Havasy, I'm going to take it to you. Similar question to you, but I mean, I've had a lot of conversations over the last few days and weeks around agentic AI, which are basically microservices of LLMs and models to connect stuff. And you're all about interconnectivity. So allowing the patient to move through from seeing their physician to getting prescriptions and seeing a pharmacist and having surgeries and going to physical therapy, all the whole thing, right? And having their bills paid by the insurers. How does AI kind of connect those things currently? Are there connections from AI looking at all the data yet? I know there's TEFCA to look over the record system, but how's AI working at the moment in that regard?
Yeah, I think we're early. We're quite early in the deployment of agents here. And I don't think healthcare is very different at this moment than what AI is doing in other industries. I mean, I saw some data recently, two sets I sort of have in my mind that I'm trying to reconcile. One was our survey, HIMSS' own survey of AI use, which just hit the web, I don't know, a week or so ago, where we're starting to see a difference emerge between what leaders believe AI is doing and how agents are helping their productivity and other measurements they use and what people on the floor who are using these agents are saying. And that was backed up by some data I saw, I don't even remember where, in one of the web magazines that comes across my feed. It may have been Forbes, might have been one of those, where that disconnect is pretty stark right now, where healthcare leaders and C-level executives are saying agents are there to start revolutionizing the process, and we have a whole governance process to deploy them. And the people on the floor are saying, oh my God, these things are terrible. And yes, I use AI, but I actually have a ChatGPT subscription I don't tell my boss about because the tools they're handing me just aren't ready yet. And so I think that's kind of where we are. We're very early in this process, and organizations are experimenting. They're learning. That feedback loop is starting to take place. But at the moment, I don't know that the agents have become very well connected into a system. There's a number of tools to help individual processes. We have a ways to go before they really start harmonizing things and making things run more smoothly.
Okay, so that's all great. And I think we're going to get deeper into what AI can do, cannot do, what it's doing right now, and what it can then do in the future. But I think one of the core here is to see really who benefits, who pays, and who is at risk. And if it's a democratized innovation, like something that will touch everybody. And I love to hear the insurance side of things with John Sapp and how it's insurance are welcoming or not this whole AI phenomenon.
Yeah, so for me, it is so my tagline and what I use in the organization, and is my job is to enable the secure adoption and responsible use of AI in the business. And what that means is helping the business to, in this case, achieve, improved diagnosis and early detection and some of the things that Dr. Pearl talked about, but also some of the things that Mr. Havasy talked about, being able to, how do we connect those things? How do we connect some of those dots in terms of personalizing treatment and being able to do different things? And if you talk more, let's talk a little bit more about the insurance, and I'm sure Robert Booker will have something, at some of his former roles and kind of thinking about how things were at United Healthcare back in the day. But we think about it in terms of insurance underwriting and claims processing and all of those things. How do we use that? How do we use AI to improve operational efficiency? And from a strategic standpoint, that's number one. Number two is improving the customer experience. In this case, patient experience, or whoever the customer is. And in my current case, it's a workers' comp policy holder. in prior cases at former organizations in healthcare, it was a patient, or it was the doctor, or it was the CMO, and all those different people you talk about. So I think there is a collection of who pays, who benefits, and the risk versus the reward. It's a balance. But for me, it is, how do I enable the secure adoption and responsible use of AI technology?
Yeah, I think it's interesting. I go back to something that Dr. Pearl said, as I am really speaking more about just general healthcare as a broad spectrum from just one perspective. I think if we actually think about the true goal of engaging the patient and maximizing the physician's effectiveness with that relationship, and continue to build a relationship of trust between the physician and the patient, which is ultimately how people seek to maintain their wellness and manage their chronic diseases and such. It's actually, there's really a paradox in my mind between the concept of making that physician relationship effective, allowing the physician to still have the autonomy to have the relationship and manage the care of their patient while having tools that enable that, versus the agent approach, which is really what oftentimes insurance companies and the large operational behemoths that run healthcare in our country from a payment and a treatment operations perspective, really are looking at. And so, I actually think somewhere in the question, Sean, you're asking, Marco, you're asking is, what do we really mean about the use case of AI? Is it about physician empowerment for the betterment of the patient? Is it about operational efficiency to deliver healthcare at a reduced cost, maybe do better jobs at prior authorizations, with, I think, a tremendous challenge of having transparency around prior authorizations, which some companies in the industry are really struggling with right now, is to build consumer confidence in their authorization decisions. And so it's really a challenging space, and healthcare has always been a challenging industry in the sense that, what are we really talking about when we talk about efficiencies in healthcare? I think it's ripe for all of those things. And so, I don't know that, as purely a patient that sees my physician for a couple of chronic diseases, I don't know that I want an agent to be the relationship with me and my physician. I want that to be a relationship with my physician. I'm happy if they have an agent to help them. I'm absolutely happy if the call operations person that helps me make sure my claims are paid is as efficient and maximized in their role as possible. So, it's really challenging to even know what we're talking about sometimes. I don't have the answer, guys. I just think about it as a problem we have to define for the consumer, who ultimately needs to have confidence in the healthcare system and choose to engage in making themselves more well and avoid long-term disease.
You always have the answer, Robert. You always have the answer. But I'm going to go to Jim. The word efficiency has come up a few times now. What's your perspective on areas that are ripe for efficiency improvements where AI might be able to help? Your thoughts on that? Not just camera failure, also mic failure. There we go.
Yeah, looks like a mic failure too. Well, then, you know what? Let me do the next step, which is I want to go back to Dr. Pearl. Dr. Pearl, we spoke many times on my podcast right after you actually wrote your first book, which you wrote with ChatGPT, which was kind of like a provocation. I know that was the idea. And you were talking about how the medical profession is actually driven still from certain, old school type of attitude towards the profession and towards the patient. That was a couple of years ago. Have you seen any improvement, any major adoption, and did you change your mind maybe on those points that you were making at that time?
What I've seen is I'll call it the culture, the values, the beliefs, the norms have not shifted very much. But individuals on their own are now using these tools, as I say, particularly ChatGPT, to be able to do things they couldn't do before, to be able to find diagnoses that might have eluded them, to be able to organize a complex medical history, think about a differential diagnosis. I'd say at least a third of physicians are using the tool in this way. What I'm also seeing is patients using it in this way. I remember a little talk I gave at Stanford Business School this summer, And in the audience was an individual, a CEO of a company, who said that his daughter had a problem, a chronic ailment that no one could diagnose. They finally diagnosed it, but he was in the seminar after that, and he put the information into play, and the differential diagnosis it gave, the 3 diagnoses, the top one was the one that ultimately a chronic inflammatory disease, which was the accurate one. I just keep hearing more and more from patients who are figuring out how to do this. They're in the hospital and they can't figure out. All the specialists come by in the morning and rounds, and they can't coordinate the care. They can't get all the common information. And so they use the listening tool, particularly in the 4.0 tool, the multimedia tool, to be able to obtain this information, to organize it, and they actually become the quarterback of the team. I think there's a lot of sub-rosa use, again, as the point that was made by Rob earlier, not in the specific applications, and certainly not in the narrow AI tools that are FDA approved, but the generative AI tools. They're doing these things on their own with great outcomes. And as I say, I go back to the DeepSeek. The fact that it's now open source, I think, will allow these companies that to date have had to use a narrow data-based application as opposed to a generative AI application. And I think they're now going to be able to come up with tools that actually empower patients and their families to both know what's going on and empower the care. And they actually will assist clinicians in making the right diagnosis and avoiding medical error.
Well, I want to.
Sean,
please, Rob. I was going to go to you, so go for it.
Yeah, I want to jump in there. When Dr. Pearl released his first book, he talked about it at one of our AI conferences. And the following year, last year, in fact, we had, I think, what was a good follow-on discussion about this. And a couple of organizations who have both experimented with asking their patients to use AI, and the Dana-Farber Cancer Institute, who deployed their own sort of sandbox protected ChatGPT instance and then essentially told their staff, go nuts, use it however you want, it's safe. Came up or really found that both sets of people began to use it as what I think we're calling a thinking partner, right? Help me understand this. And what I saw was a connection to something 15 or more years ago. There was some work that came out of Northeastern University about using the very first agents, right? They weren't AI powered, they were just algorithmic. And in particular, in Boston hospitals, for using these agents to deliver discharge instructions to patients, right? It was an avatar on a computer, probably 16-bit graphics, right? Like old playing a Super Nintendo game. But what rose to the top of the patient's reports on their experience was, I feel better talking to the agent because when I don't understand something, I don't mind asking it to repeat itself, but I don't want to be a bother to a nurse who I know is so busy and has other things to do, so I never ask the follow-up questions. And I think what we're seeing, to Dr. Pearl's point, I'm seeing also, and I'm hearing from HIMSS members who are telling us this, we're beginning to close that information asymmetry that's always been behind a lot of the doctor-patient relationship, right? Because doctors go to school for a very long time, and most patients don't go for those same subjects for that amount of time. And AI can help them close the knowledge gap. And it gives them a thinking partner to ask questions asynchronously, offline, after the visit, or to prepare for a visit. And I think that happens on both sides. I know pediatricians tell me they use it all the time to distill concepts into ways that younger people or children would understand. And I know patients say, yeah, I know what the doctor said and I remember the words, but now I kind of have a deeper understanding. So that thinking partner, that asynchronous thinking partner, seems to be the way the use cases are evolving, from at least what I see right now.
That's right.
John, I'm gonna take this question to you. Marco's gonna beat me up for making it too long, but the idea that, to Rob Havasy's point, it's a partner. The way I visualize it, and then I'll go to Jim with this after. The way I visualize this is, it's a way to look for the treasure. You can kind of search the map looking for treasure while you're undoing a Rubik's cube to solve a puzzle to end up at a great result. Do we see opportunities for precision care? Have we seen opportunities for precision care where AI is helping along the path for research and making decisions? And then how does that, we'll touch on the risk a little bit here, how does that impact will a doctor stand behind or a physician stand behind a result that comes from ChatGPT or some other LLM model that's helping them along in this journey?
So my thought on that I've got a few different thoughts on that. The ability to improve diagnosis and early detection is certainly part of that treasure. The ability to personalize treatment, part of that treasure. Remote monitoring and telemedicine, part of that treasure. The whole concept of natural language processing for documentation and being able to understand all the information that may be in a patient's medical record. When you think about more of a longitudinal patient health record across all the different providers of care that an individual patient may have, being able to analyze data across all of those in a very short order to be able to maybe identify something that standalone the physician would not be able to do. So I think that's part of the treasure and the opportunity here. Part of the risk in that is, you still have to have a human in the loop to be able to validate that information. If you think about how this may apply in some medical devices and utilization of those medical devices based on AI becoming now a component in being able to determine the right flow of anesthesia, let's say on an anesthesia cart to a patient based on condition, age, and a number of other factors that maybe might deliver a more appropriate flow of anesthesia. So lots of opportunity, but the risk in that is you've got to go through validation and all the things that the FDA may require. And so there are some things like that we have to think about from the I'll call it the traditional security technology side of things, because you've got the evolution from traditional AI to Gen AI to agentic AI and all these things that are now evolving from it. Having an autonomous agent and all those pieces, right? So you certainly have to balance the reward that may be associated with this form of innovation and how do we move things forward. So I think it could decrease the overall cost in the healthcare system, which is certainly a component. So improving, getting rid of some inefficiencies, certainly, a benefit. But we have to make sure we don't do so at the cost of privacy and security and validation of the information that comes out of those agents.
I build on what John just said for a second. The personalization, I think, is going to be one of the most powerful parts of this. And Robert Booker was talking about it. He had a couple of chronic diseases. I'm not going to ask him what they are, but let's say one of them is hypertension. So you see your clinician, you're diagnosed with hypertension, you get a medication. You could get a wearable monitor. They're reliable, they're inexpensive. At the end of the month, you have 100 readings, 92 are normal, 8 are abnormal. How are you doing? You have no idea. I'm doing great. I got 92 that are normal, 8 that are abnormal. First and second derivative, easy analysis by a generative AI tool can tell you. And after 1 month, if you're not doing better, now your medication's changed rather than waiting 4 months to see the doctor again. And then when it's elevated, it's white coat syndrome and everything else. Yep. Think about a nurse. Yeah. Nurse provides equal care to all the patients for the most part across a medical surgical unit. Who are the patients at risk? Whose monitors at the bedside are showing data that's not yet terrible enough, but it's bad enough to indicate it needs more intense intervention? This is the personalization. And I think that the opportunity to be able to control chronic disease and avoid these complications, that's not only where the quality is going to come, but the cost reduction is going to result.
Absolutely. And I think that fits in well with what we're seeing in Altarum, which is as you look at it from a public health standpoint, matched up with the dollars and cents of Medicaid. If, as Robert and John have indicated, I can translate individual results at a personalized level into larger analysis and data in pharmacogenetics and various aspects of population health data, in regional variations and demographic challenges relative to care delivery, that then give me, just like Dr. Pearl said, hey, I've got 8 readings that are bad. Well, in the context of where you live, what your demographics are like, other population health data, we can narrow down a personalized decision that you need an intervention. And that intervention may not apply to 15 other people, but it applies to you under these circumstances because of the algorithmic tuning to be able to tell you that's the value. or pharmacogenetics data that says, hey, you know what? There's probably a good chance that the medicine you have for that chronic condition has only a 60% efficacy versus other folks in the population relative to you. So you have to have some other fine tuning being done.
Yeah.
So let's talk a second about privacy security. So I welcome, and I do it all the time. I may joke. I just spoke to Dr. GPT and see what he says. Of course, it comes with a note that says, well, look, you should also talk to a real doctor, right? So I think there is a fact of education that if we want people to use these tools, we should probably kind of teach them how to and where to draw a line before they maybe damage themselves, like just listening too much and maybe there is a mistake. But the other thing is I feel like a lot of people do not use it properly because they are afraid that this data that they share with the agents is going to be obviously feeding the algorithm, feeding the knowledge base, but also ended up in the hands of marketers or people that are going to use it in the wrong way. So I don't know who wants to take this, but let's talk about privacy and how we can actually use this powerful tool.
Yeah, I'm always happy to jump in on that one, Marco.
Go for it.
I think challenges and considerations are certainly data privacy and all those things. But when you think about AI governance, which is one of the things you have to have, the first thing as an organization, if you're going to use AI, have a strategy. Know what that strategy is. Is it improving operational efficiency? Is it customer experience, patient care, whatever it is? Know what that is so you can define a set of use cases. Then you can establish governance around it so that now you can have your principles for the responsible use of it. And, that's where, I talked about enabling the secure adoption and responsible use, because what we want to do is we want to remove the fear from it while also providing the guardrails around which people can utilize the technology, making sure that there is data privacy, because there will be concerns because PHI is involved, PII is involved, a number of things. And, people have to understand there's a difference between anonymization and de-identification. They are not one and the same. You talk about bias and fairness and, the decisions that are made. Right now, the FTC has an investigation going into, I'll call it a management consulting company who built an app that made a decision on the eligibility of patients for Medicaid benefits. So now there's a bias that's being proposed and or a harm that's been brought to these people, and that's under the safety principle, because people think safety, they think physical safety. No, it's not just physical safety. So we have to take all those things into account, and of course, at the end of the day, it's the regulation and accountability that comes with it. So I think those are all things we have to think about as we do it, but do so in the context of enabling the secure adoption and responsible use, not to try to prevent people from utilizing it.
Yeah, and my work so far with the Coalition for Healthcare AI and actually another industry group around healthcare cybersecurity, we're trying to break down a lot of the principles used for traditional IT security governance and data governance and see how do they apply to a unique AI model. And John was highlighting some of the challenges. You can have the most secure system in the world from an AI standpoint, but if there's inherent biases or the ability to maliciously influence decision making within the learning model, then that creates a whole nother challenge that isn't necessarily addressed in traditional security paradigms.
Yeah. Well, I think our experience from our research would show that the people in organizations that are oftentimes responsible for AI governance and the AI strategy may not be the people that have traditionally been involved in risk management from a cybersecurity or a information protection point of view. And so there's actually a communication challenge to create solutions around in the space to say that, many of the common principles that we've embraced specifically in the advent of cloud computing, such as working with service providers and those concepts, are portable to the use of AI as long as we understand the use cases and the strategy underpinning it. And to your point, Jim, it's ultimately transparency, right? So can I explain the outcomes that I'm getting? Is there transparency around it? But Marco's question was fascinating to me because, Marco, you framed it as a consumer choice, which is the consumer saying, I want to go, put the question into Dr. GPT. I'm going to steal that, by the way. So I'll use that term in other conversations. But I think,
just quote me.
Thank you. Well, you get all the attribution, Marco, I promise. But I think, but ultimately, it's like consumers are going to go where the consumers give their information to providers that we all could name here every day, and you really question you question the promiscuous nature of their habits. They just send everything to the web, right? Because I get free email, I get free mapping software, I get whatever it is, right? So I think we're at the advent of that as well. I mean, if the solutions are perceived to be providing better value than what I traditionally get, or I just feel like I have more engagement in my care, I'm going to go do that. So I think the argument for those that actually are trying to create these solutions, in a formal manner, is to create solutions that are as compelling or more compelling, and potentially can be demonstrated as more trustworthy than the solution that a consumer can just, go off and say, I'm going to use DeepSeek today or ChatGPT tomorrow, or, the next solution the next day to try to find the best answer I need. It's, again, I guess I'm always asking the question with no easy answer, but I think that's really a challenge. But I think organizations, to the point that Jim just made, I think, the explainability and the governance problem is really important, and we have to create language within organizations to actually explain and understand what we're doing. And we also have to just really look at where the data is coming from that we're relying on to create compelling models. And is that data coming from the organization's own data, in which case new life cycle practices are important to consider, or are you getting it from a general purpose trained model from one of these well-known named providers? And how do we know how much PHI was oriented around the creation of that model or not? They would say not, but I question sometimes whether we know. So so
here's a question, if you don't mind, from the audience. I thought it was pretty good and on topic. So the liability, let's say you go and you listen to your agent AI, and then things don't go the way that are supposed to go. Who's responsible? How is going to work the finger pointing at that point?
Margo, I'll jump in on this one quickly, but I know there's other constituencies here who want to weigh in. I think the question right now is, the courts are going to answer this. There is no answer right now, right? And what I see from an organization that represents almost all of the constituencies, maybe patients less so, but certainly providers, and then nurses and employees and market suppliers and builders, right? We're in the classic healthcare. It's them, right? The position of many physicians is that they want full control and input in how AI is developed, but none of the liability if it goes wrong. The point of the developers is that they can't accept liability for someone misusing their products. So this is one of those things that America tends to solve in the court system. Right. And at some point, we're going to have a wonderful case of a malpractice insurance company and a physician arguing this out, and we'll solve it. But I would say from inside the sort of system right now, with all the constituencies talking at once, they're all sort of saying we want most of the control, but a very little of the liability. And I'm not sure it's distributed itself yet.
I would differentiate a general AI, a large language model, from a specific application.
Mm-hmm.
If you're talking about ChatGPT and you ask it a question and the answer it gives you is one that leads to harm, it's hard to imagine that they're going to be able to blame OpenAI for that. But if you create a bot specifically to make a diagnosis and it makes the error, then it's behaving like a clinician, not like an encyclopedia or not like a browser. And I think that's where you're going to have the specific challenges and why there are so few today in terms of generative AI. A lot of narrow AI, 1,000 are approved by the FDA because they are approved on the data set. And that's where the liability derives. But the pre-training that is sitting in place. I also think, though, that the two are going to fuse over time, because people are going to take a large language model like a DeepSeek, an open source one, and then add on top of it a million human to patient, clinician to patient interactions, and actually learn the advice the same way you do as a resident in medical training. And that is going to make the applications better. And I'm going to propose that the way you test this, you should test it against humans. You take 100,000 patients, You have a human interact, you have the technology interact, you then have independent observers evaluate the two, not knowing which was created by a human and which by application, and you give FDA approval when it's 10% better. Because I think the challenge we have is we're holding a technology to a higher standard than we hold humans. I think we have to ask, not is it perfect, not is there risk, but is the risk more or less? Going back to what Robert Booker said earlier, is the risk of a generative AI tool more or less than using Google? Is the bias coming out of a tool more or less than patients have in clinical practice today based upon studies from New England Journal of Medicine and a variety of other areas? Are the number of misdiagnoses greater than the 400,000 people, or is it going to be less? And I don't think we have yet brought that thinking into our evaluation of technological tools.
We haven't, Dr. Pearl, and I think it goes back to what Rob was saying. I think just our community and culture of liability and litigiousness makes it hard to come up with answers to say we had 25 documented medical errors that we're willing to reveal in these details that serve as training information for the training model so that the model doesn't make those. I'm not the physician, but I have a friend who's a physician who has argued with this with AI when he says, compared to what? Compared to a resident that just got off a 36-hour shift trying to sort through incomplete information,
exactly,
when an AI could give him the answer and probably have it 89% right. Is 89% good enough? We do a lot of things around 89 and 90% for patient identification and patient matching, as well as just the efficacy of their medical record or their drug list. So yeah, it's challenging across the board when we aren't willing to admit this is where our baseline is, and this is how we can build upon and improve otherwise.
Yeah. Well, go ahead, please.
Sorry, I was going to say we have examples from other industries too, right? NHTSA, the National Highway Transportation Safety Administration, did this over years as autonomous driving systems came in, right? Yeah. Maybe not complete autonomous driving, but certainly automatic braking, right? Yes, everybody's automatic braking system has a phantom thing. It sees a tree or a road line, confuses it, and the brakes are applied for a second. But on balance, that's still a lot better performance in avoiding accidents than most humans are. And so we can, healthcare tends to not look outside for other examples, but I think there are some other risk reward kind of examples out there we could look at. Sorry, Robert.
No, it's no problem. I actually, Dr. Pearl said something that just really resonated with me, which was, we routinely know that physicians are trained by mistake. I mean, the whole concept of looking at morbidity conferences, as tragic as those things can be. They teach and they provide education. Yet here we have maybe a corollary in technology that we've never seen before, which is the same opportunity, but there's going to be a different standard applied because it has a lack of humanism in it. And I just think it's a fascinating challenge, but also I think the analogy is so strong, Dr. Pearl. I think we have to continue to remind ourselves that it's really not unlike making a doctor. It's just making an electronic tool that would help a physician, right? So.
And Robert, I think I'll be controversial because I think you've opened a door there and follows on with Dr. Pearl's comments, which is, the art versus science of healthcare delivery of right. medicine, and how perhaps in some cases that AI opens the door for realizing so many things are process or procedure or a billing code or a prescription. And there are certain percentage of cases and engagements that the humanism is involved, but how many diagnoses in the ER and how many cases could go through just in following a process flow around a trauma or a particular presentation of complaints and symptoms that, AI could step in. I think that causes cultural challenges. I defer to Dr. Pearl and others, but I think that causes some concerns in saying, gee, could this tool really do my job?
So I'm going to pose this question, and I'm sure everybody will have another go at it here. When we look at risk management, and we've done this now looking at security and privacy, right? We have a lot of standards and regulations to help with that, and organizations to help validate that there are controls in place, all leading toward better patient care. How is this technology different in terms of risk management? Because when I look at it from just like a quality of service perspective, endless opportunities, endless paths of where this thing can go. And it's not just an incident of data loss. It's actually perhaps making decisions on what care to provide, what prescriptions to deliver. So how does risk management change with this technology?
Well, I think it's significantly expanded. It's another component of enterprise risk management. Just like cybersecurity has a risk management piece to it. The way I look and think about cyber risk governance is cybersecurity and technology risk are two parts of cyber risk. This is just another category of risk that is technology risk, but it's just a different category. And so you balance it against, okay, what are the threats? The threats are those things in your guiding principles, safety and making sure that it does no harm, that there's no bias, and all of those, 5 or 6 things that you look at the AI risk management framework from NIST, and it kind of gives you a good guide, but it's just another category that now, okay, how do I collect the data that gives me visibility? Because governance is about visibility, so that an informed risk-based decision can be made. And so it is, how do I frame that up in a way that an informed risk-based decision can be made based on the risk appetite of the organization who is making that risk-based decision?
If I could offer a controversial view, I would separate this into 2 kinds of risk. There's the technological risk, the ones we've been talking about, and that's not going to be any different in generative AI than other forms of AI in social media and all the different ways that we're exposed to the general public. But I want to focus a little bit on medical risk. And 250,000 people die every year from preventable medical error, including my dad, who started one of my story of his death, started one of my books. And right now we do it in a retrospective type of way. If you think about a generative AI tool, it actually can watch the care being delivered. It can watch what a doctor or a nurse does. And the medical errors we're talking about are medication errors, central line infections, hospital-acquired pneumonias, 250,000 people dying every year from these mistakes. And why do they happen? Because people cut corners. And what's this technology very good at? Watching someone and then being able to tell them when they deviate from the best practice, from the agreed upon practice, from the expected practice, whatever word you want to do. Now, how will clinicians view that? I think the systems could conceivably, again, save tens or hundreds of thousands of lives, but there's going to be an invasion of privacy. And clinicians don't do a very good job when they're criticized, particularly by a application technology, for the errors that they are making. So I just throw that out as not this year or next year. This is 5 to 10 years in the future. But right now we have multimedia applications using generative AI, and they're just going to get better over time, being able to watch, observe, compare to expected.
I'm just going to throw this in there. My concern is I don't believe organizations are doing that risk analysis. I think they're going to follow Robert Havasy's point of, we'll do it and let the courts figure out where things didn't happen correctly.
Well, I think
you mean fix after?
Yeah, you fix it later.
Yeah. I think you see a stratification there, Sean. I agree with you. Some are probably charging ahead recklessly, but look, I have an anecdote from back in the days when I was doing a lot more with telemedicine, remote patient monitoring, and brought to some actuaries in risk management at a large healthcare system that I'll remain nameless. And we laid out all the use cases. Patient might think we're monitoring this data 24/7 and we're not, and all these things could go wrong. And the woman looked at me and said, "We just did a face transplant last week. We'll figure it out." And so I think there's a lot of organizations that have experience doing some quite dangerous or some quite other things who are thinking about this, and those best practices will trickle down.
Yeah, I would say I'm not going to name names, but I'm sure all of us have read articles about large health systems that are plugging in nurse practitioners in areas where physicians used to be, and the challenges systemically with how they're registered and how they're certified and the education they get. How does that compare with the ability to have one certified FDA-approved AI that may be working on their behalf or doing something that otherwise right now is just left to choices around staffing and logistics.
Yeah. One thing I think about with all this is I think our inclination as risk managers and sometimes individuals that have a strong compliance, mission or orientation, is to wait for regulation and compliance to sort of define the space or define the need. And I would argue, and really, I think Dr. Pearl's example was really helpful in terms of the real risk that we already have in our society. I'm not sure regulation will catch up with this, frankly, forever, but certainly not in the next years. And so the organizations, to John Sapp's point, the organizations that are implementing governance practices, that are working to define their risk and manage it, and they're good frameworks out there to do those things. The organizations that are doing those things, I think you could make the argument, are taking a responsible approach to understand the risk as they see it today, versus waiting for a regulation, which may not actually solve the problem at all, but it will give us some comfort that we can at least claim in the public square that we've solved the problem. So I think this is really about organizations that are being responsible, saying, I'm going to take the initiative to manage my risk and to have transparency around my use of these tools, and to try to do good with them, but also do good in a way that I can explain what I'm doing.
I want to go into who is benefiting from this, because Rob, you talk about going to the market first and then fix it later, which we hear a lot in technology. I'm not sure is the right attitude, but a lot of companies do that. But of course, not when you play with people's life or health. I think there is an ethical line right there. So as you roll this thing out there, I think that the patient can benefit because they get a second opinion, they get a consultant, on the fingertip every day. But I feel like, is it something that needs to be regulated? And I'm not sure you're going to let it to the market to decide. So I don't want it to be, in an ideal world, an economic decision, and that's tough in our society. So I love the round from you guys about the ethics and the how we could avoid a Wild West where people are just going to go and mine gold and come back rich.
Well,
Rob?
there certainly are. Sorry, go ahead, Jim.
Oh, no, go ahead, John. I'll follow up with you.
Yeah,
I want to hear everybody. So.
Oh, well, real quick, there absolutely are ethical considerations, and there's some really good questions in the chat around some of these things. But at the end of the day, we can't let fear of what may go wrong prevent us from advancing forward. That's why, my statement, and this is the value statement that I'm using in my approach to this, is just enable the secure adoption and responsible use of it. That is to me, if we start with that as the outcome and the value we're trying to achieve, we live in a litigious society, and America is probably the worst of them all, but we can't let that be the thing that causes us to go, oh my God, wait, we got to stop and wait, because I think Dr. Pearl has had some exceptional points, and there's risk in everything, whether we're trying to come up with a cure for cancer or something else. There's risk associated with it. There are unintended consequences, but it is, do we stop pursuing the goal of improving? No, it's we just have to do so responsibly.
Yeah, I just echo your comments, John, and I would add, as part of that having to advance, I think we brought out several themes here about the fact that there are demographics changing in the population. There's demographics changing in the availability of our physicians and the availability of our specialists. I think the way we as a group and others are thinking about it now is the deliberate thought that has to go into it before it gets to be a crisis, and it's AI versus nothing in certain parts of our geography.
Yeah.
And building on that, Jim, I think you're absolutely right. Again, we tend to ignore people who are socioeconomically challenged or sitting in rural areas, and they're not getting the care today. That's the starting point.
At all.
And the question is, will this close the equity gap or will it expand the equity gap? And I'm a big believer that if done well, particularly with community support, it will close that equity gap far faster than anything else we can accomplish.
And lately, I've been thinking of it this way, because we just sort of created an example of something that's been on my mind. We talk about the technology, but we're worried about how the technology is used. And those are actually two different things, right?
Yes.
The proverbial argument that whatever side of the debate you're on for gun control is you can leave a gun on a table forever and it won't shoot anybody till someone pulls the trigger. When I hear nurses, doctors say, I'm worried that AI is going to take my job, what they really mean is I'm afraid my boss is going to replace me with AI. And that's not AI's fault. That's not an intrinsic characteristic of AI. That's how organizations choose to use it. And regulating those ethics, regulating those rules matters. And our intentionality of when we talk about this matters. And I'll use an example from an internal conversation I had, because we were talking about whatever part of HHS had new regulations, as we do at HIMSS and other similar organizations. But I said, if our concern is really about how employers are going to deploy AI, shouldn't we be, talking with the Department of Labor here too, which tends to get left out of healthcare conversations? And so one of the things I'm trying to do is be a little more intentional with the language. Where am I worried that it's truly bias in the training of a tool and the tool that's going to cause some sort of harm? And where am I worried that it's the people using the tool that are using it in a reckless or irresponsible way that's going to cause harm? And make sure we're intentional about which of those two problems we're solving.
And organizations that are going to be reckless are always going to be reckless.
Yeah. But they tend to flame out, I guess, once in a while. They're not always just
right. Burn bright, burn fast. Exactly.
Yeah.
So I'm gonna
Sean,
yeah, go ahead.
Marco, sorry. There was a question in the chat from the audience, and around if AI is going to drive efficiency, and we've already seen where it's created risk and vulnerabilities. But the question more was about, will patients be able to opt out of AI diagnostic tools? And I thought that's a thought-provoking question that I'd like to hear what this group thinks about that.
But do they need to? I know we've seen some of that. Well, I'd like to opt out of AI. Really? Okay. Did you opt out of the PAC system? Was there something about your CT scan that you thought was a concern with regards to GE versus somebody else's system? And so I think I believe we've artificially injected this conversation about, I'd like to opt out of the doctor's use of AI. Great. Are you going to opt out of Epic as well? Because that's what's holding your EHR, as well as providing the diagnostic assistance. So where does AI as something that a patient opts out of new versus the rest of health IT?
Well, and Jim, I think that's where the regulatory landscape that we live in today is ill prepared for the challenge we face, because ultimately it's still EPHI. So the first reflexive answer is going to be, well, I can opt out. I can ask for transparency over who accessed. Well, how do you do that really? And then we talked about bias several times in this conversation. I mean, the whole fact that the system's based on a historical health data set, longitudinal data and such, claims data and such, that has inherent bias in it, because healthcare has been delivered in a biased way in our society for so long. So to some degree, opting out doesn't solve the problem. It actually hurts you in the long run, because it reduces the data.
Let me point out that this is exactly the trajectory of every technological advance. ATMs are the great example. You go back and you read what's being written at the time. Everyone was certain the machines were going to eat their money, never give it back. They would never use it. You go to online banking, same situation. And yet what happens is you get used to it across time. What you see is data that says it's actually better. The Stanford did a study of clinicians against AI, and AI was 10% better at making complex diagnoses. After a while, you don't see it the first time. You start to embed it, and you go from being certain it will never happen to being possibly that it will occur, and then how could it not have been inevitable? And I think that that's the trajectory we're going to see. Now, whether that's over 5 years or 10 years, I think we don't yet know the trajectory. But remember, this technology is doubling in power every year. It's going to get twice as good in a year. It's going to get 30 times better in 5 years. And I just want to make sure that we're looking out into the future, not trying to manage what exists today, because tomorrow it's going to be different than it currently is and far better.
I'm going to opt out from flying because I don't want an AI to land my plane.
Exactly.
It probably does, by the way, right now.
Exactly. No, I know.
A lot more algorithmic control than you care to think about. So,
right.
Well, there's a ton of stuff
that's a great point. I mean, we talk about AI in air quotes, and we already talked about some things, the multi-agentic structures. But for those of us who are kind of diving into it, there's chain of thought, there's zero prompt reasoning, the mechanics behind this, for those old of us to remember it. It's kind of like comparing the Betamax versus the VHS, which is each is a videotape recorder. Okay, but which one is going to be the one that we all choose to go with in the future?
Mm-hmm.
So we're closing on time here. Sorry, Rob. I'm going to go quickly.
You're the boss.
Go quickly.
I was going to say to that last point, there's thousands of people walking around right now with pacemakers in their chest, with algorithms making decisions about when to shock their heart, and
Right.
we've gotten used to that.
Yeah. So I want to use these. There's a lot of questions and comments about outcomes and resilience and risk management and everything. A lot to cover. We only have a couple minutes left here. I want a word from each of you. What's the one thing you think we need to get right for this to be right?
One word?
Yeah.
Word of
one.
Governance. That's my word.
That was my word.
Oh, I'm sorry.
Well done,
Well,
Chip.
you could
No,
say
that's
that.
okay, Chip.
That was my word first.
I'll call validation. You do governance, I got
2-0.
validation. So
Yeah, good.
I'd say understanding. This is a tough technology for your average person to wrap their heads around, that it's just a predictive word engine. And so understanding is going to be important.
Yeah, and I think just with governance, being able to let's not write policy to the point of trying to. Sometimes policy for governance gets written to have a defensible position by an organization versus how do we truly utilize it to make improvements, because we're all chasing continuous improvement anyway in everything we do.
I think we have to be objective and not allow human bias to cloud our thinking when it comes to this technology. We have to acknowledge the mistakes that people make, the opportunities of the technology, and we have to make certain, based upon good scientific studies, that the technology is superior to humans. And when it is, I think we have to acknowledge the shortfalls of human error and human decision-making.
And I'm going to say kind of the same thing in a different way. A lot of the view I see is around the technology and its innovations. I think it's an opportunity for humans to be creative as well, and perhaps think of different ways to diagnose and deliver treatments. So let's not forget the human part of this. Marco, you want to say something?
No, you stole it from me. I'm the human guy. So
you're the human
please. No, I mean, I think this is. I think it's a fascinating conversation as we wrap up this. I'm really, really happy that we got to start our webinars with this. Great participation from the audience. I know we had a final question, which usually is the future, but I think we kind of already went over that in in all the comments that we took care of here. As far as I'm concerned, it's also a common sense, which I like to say is not that common, unfortunately. So,
and it's not the last conversation either. I mean, this is going to be something that continues, and
we will follow up on this for sure. So, Sean, you're up.
I'll wrap, and I'll start by thanking the folks that joined us live and participated in the exchange. Great feedback, great comments, great questions, and of course, huge thanks to the panel that decided to join us and have this conversation with us. Obviously, we couldn't do this without you and keep the conversation going. ITSPmagazine is all about making people think and then hopefully doing something with their thoughts, take some positive actions for society and leveraging technology to do that in a safe and secure way. So we're all about that. I believe we achieved that today in this webinar on AI in healthcare. So Robert, Jim and John, thank you all. And thanks again, everybody, for joining us live. Stay tuned for more. Please do follow our channel as well. I'm going to put up this here. So you can click that link for folks that are watching. You can follow the channel and get a notice of all the other upcoming episodes of our webinars. So thanks, everybody. We'll see you again soon.
Thank you all.
Thank you, everybody.
Thanks, everybody.